Tony, whenever you're ready.
So here we go. So hello everybody out there. I wish I could see all your lovely faces, but I used to work in radio, so I'm just going to talk to you all, and we're going to hopefully enjoy ourselves. So once again, good evening. My name is Alan Anthony Amberg. My nickname is Tony, and I'm a nurse practitioner with the Psychiatric Consult Liaison Service at Northwestern Memorial Hospital. So we're going to begin with our 3 slides that we have to put about our series as a whole. There are no conflicts for anybody to declare. And there we go. So we've got 3 course objectives that we're working on. And one of them is explain best practices with the diagnosis and treatment of alcoholic hepatitis, outline best practices with the diagnosis and treatment of alcoholic cirrhosis. Both of these are going to be covered by my illustrious colleague. And I'm going to look at best practices with psychosocial treatment of alcohol and referral sources. Actually, what I'm going to do is sort of begin with the basics and walk you through pretty quickly. And hopefully, I think you'll be in a good place for the other 2 presentations. So what do you got to do? So you got to be present for the entire session. You've got to complete the evaluation form and return the evaluation form to the staff, right? So here are all the details, and this is a CMA program that has been approved through Rush University Medical Center. So thank you, Rush, my alma mater. So let's proceed on to the program here. So, this is an update, and again, I'm presuming that many of you have some experience already with alcohol use disorder. So forgive me if I repeat some things that we already know, but I think are worth taking a look at again. So hooch, moonshine, liquid courage, it's a joy, and by any other name, still a dangerous problem to us. And we have to remember that addiction or use disorders, depending on whether you're speaking according to the ASAM, the Association for Addiction Medicine, or DSM-5, a use disorder, these are brain diseases. They are not failures of character or morals. And this is very hard for us to keep in the front of our minds, even those of us who work with it all the time. I was sitting in a session today where we were discussing the ethics of working with a patient who had heroin and cocaine use disorders, and how his behaviors kept him leaving the hospital, getting worse, coming back, getting worse, coming back. And there was a lot of frustration about it. And then we considered the question, what if this is a person who can't control their diabetes? If we say they're an addict, do we feel differently about them than we feel about the person who's coming back because they can't control their diabetes, or they keep having exacerbations of heart failure? So we have to keep in mind, even those of us who work with it every day, that these are actually demonstrably brain diseases. So on the left, we can go to the great bard, because alcohol has been part of our culture for thousands of years. And for most people, wine and spirits make for good company. Good wine, good welcome can make good people. However, it's the other side of the coin that we worry about. And here's a quote from As You Like It. I pray you do not fall in love with me, for I am falser than vows made in wine. And of course, that's one of the things that gets folks with a use disorder into trouble. They start to become people who cannot be trusted, and that makes it so hard and so heartbreaking. Alcohol has been a constant human companion for years. Recently, I read about one of the oldest beer recipes from China, 9,000 years old. But Sumerian culture in Mesopotamia documents wine 3,000 years ago. Of course, wine is in the Bible, the Norse mythology, in the great hall of Valhalla with horns of mead, the gods of wine. And in our culture today, everything is an excuse to drink. We have a circumcision, we even give the baby wine. We have communions, we use wine there. We have coming of age and weddings. We have falling in love and breaking up. We drink through death, we drink through divorces, we drink when things are great at work and when they're not so great at work. Now, it should be noticed, some cultures don't drink at all, but even there we have people who have use disorders. So it's complicated. We have this complicated relationship with alcohol. We're always dancing toward the edge. And we hope that we can stay right there. So if we look at this quote from Macbeth, it would have us believe that alcohol is something that, yeah, it may provoke our lechery, but it's going to take away our ability to act on it. And yet conservative estimates by one study show that 1 in 8 American women have had sexual assault involving alcohol consumption. We hope that it's a harmless adjunct to celebration and we can handle it. Look at the numbers of deaths here in Illinois. 5% of all deaths directly or indirectly related to alcohol or drugs. 40% of accidental injuries and deaths related to alcohol. Now, these are relatively small numbers. Many more people than that use alcohol recreationally, but think of the impact that this has on families and communities. So what do we call it? The language is changing here. So use disorder is the newest version of the DSM, the DSM-5, and the DSM-5 refers to a use disorder by starting and looking at the difference between it and how we normally should get our good feelings. And we normally ought to be getting our good feelings from adaptive behavior, from things that we do that make us feel good, you know, falling in love, being parents, the satisfaction that we get from work or from nature or from friends. What we're doing is we're circumventing that and going to direct chemical stimulation of those pathways. And what we're getting is a pathological pattern. And we know that it starts off with positive rewards and ultimately leads to negative rewards. And all of this changes the actual neural networks in our brain, and that persists past the activity of the substance. So again, one of the differences is lots of people have changes in their brain pathways while they're drinking. The question is what persists afterwards. So to have intoxication, now intoxication is both physical symptoms and problematic behavior, but is not necessarily a use disorder. We know lots of people who get intoxicated, but they do not have an addiction or a use disorder. So intoxication, symptoms, and behavior. We know that this can set up psychiatric phenomena for us, depression, anxiety, psychosis, and that these can exist not only during the course of the use, but can persist for a month afterward. All right? So the criteria I think we're all familiar with. We've seen these before. And so there are 12 symptoms listed in the DSM. And let's take a look at how the ASAM criteria, the Society for Addiction Medicine, calls addiction. And their definition, a 2011 white paper, is that this is a primary chronic disease of brain reward, motivation, memory, related circuitry. So let's look at that again. We know from taking a look at scans of the brain that, and the uptake of glucose and other things, that this is not simply a temporary phenomenon. We are altering the actual circuitry of the brain. Where is it happening? The nucleus accumbens, which is the center of our reward system. A lot of people think that the head of the penis of the clitoris is the place of pleasure, but of course the nucleus accumbens is really where it's at. The anterior cingulate cortex, the basal forebrain, and the amygdala and the hippocampus. Let's pay attention to those two They play an important part. The amygdala, part of the limbic system, and what it does is it instantaneously looks at all of the stimuli coming into it and makes a determination, is this friend or foe? If it's a friend, how much of a friend? If it's a foe, how much of a threat? This is pre-conscious, happens almost immediately, and happens into the hippocampus, where the amygdala is comparing the stimulus to the memories that we keep in the hippocampus. So judgment, executive function, and suppression of impulsivity are impaired when these other areas have their circuitry tampered with. We believe that there are genetic factors. It's still unclear how much. And we've already said that addiction includes behaviors, cognitions, emotion, and interactions. The ABCDs. Can a person consistently abstain? Do they have an impairment in behavioral control? Do they have a craving? And do they have a diminished recognition of what this is doing to them? That's really important. Are they able to accurately see what they are doing? And there is a dysfunctional emotional response. Again, I think most of us are fairly familiar with these things, but it's worth looking at again. So, yeah, chasing the dragon, this is a phrase that heroin addicts use, but I think it really paints the picture beautifully. People have those initial beautiful experiences, and then they can't get them back. Tolerance develops to the high, but not to the low. So people have less and less high and deeper low, right? And the hippocampus keeps driving that cycle because it remembers that previous euphoric behavior, or for that matter, dysphoric experiences when we go through withdrawal. And the amygdala is trying to calculate what's the risk of me taking this action versus how bad I'm going to feel with withdrawal. So we've got that calculation constantly going on. So let's take a look at how it works. Alcohol, cheap, legal, and several drugs in one. No wonder we love it. So let's take a look. Alcohol hits the opioid, cannabinoid, GABA, and glutamate pathways, among others. And the opioid pathway, it's not quite the same action as taking an opioid. What it does is it goes after the peptides, the enkephalins, which bind to various places in those circuits in the brain. And note that one of those places seems to be the central amygdala. So if that part of the brain is the one that governs looking at everything and trying to figure out how much is a friend and how much is a foe, all of a sudden you're given that nice opioid activity in the central amygdala, and things just seem better. Even things that ought to feel dangerous, ought to be painful, ought to create anxiety. Instead, that kind of gets numbed out and replaced with that nice opioid reaction. It's interesting, it also works on the marijuana pathways. So initially, what happens is marijuana reduces reduces the effects of alcohol, but over time it enhances the effects of alcohol. The GABA pathway. So GABA is our dimmer switch, right? Glutamate is our master excitatory neurotransmitter. It turns up the lights, it turns up the music, it brings life to the party, right? So what's its opposite? Well, GABA is that dimmer switch, turns down the lights, turns down the music, makes life a lovely place to be. So it works at a part of the GABA-A ion-gated pathway. The GABA-A pathway has to do with regulation of chlorine into the neuron. And one of the reasons why we like this at times is that it reduces anxiety. This is the basis of many of our anti-anxiety drugs, to calm the neuron. The glutamate pathway, excitatory, alcohol inhibits that at the NMDA receptor. So remember, the NMDA receptor is a place where we also have medications that, if used incorrectly, can have psychotic effects. So remember that, it becomes important. Um, Alcohol works at serotonin and melatonin, raises those pathways up. So you get that nice effect there. Alpha-2 agonist effect. So remember that the alpha-2 is the one that tamps down the fight or flight response. I mean, it does many things, but when we go into fight or flight, and alpha-1 and beta-1 is doing its thing with the heart, and beta-2 is doing its thing with the lungs, and alpha-1 is doing its thing, regulating blood pressure to the skeletal muscles so that we have blood to fight or flee. The alpha-2 is what calms this all down. And of course, its action we see in medications such as clonidine, guanfacine, and dexmedetomidine. These are the principal alpha-2s that we look at, though other medications such as mirtazapine have an alpha-2 action as well. So when we suddenly stop alcohol, the reverse is devastating and life-threatening. So again, we want to imagine that a person is drinking, and let's go back for just a second, and as they drink, they build up all of these lovely effects. On the other hand, homeostasis works against that, right? So the body is trying to bring down all this GABA that's being built up. It's trying to raise the glutamate that's being inhibited, and so on and so forth. So when we withdraw from this suddenly, now the opioid pathway is not being stimulated, and you get increased pain, anxiety, and distress. And guess what? One of the places that's happening is in the amygdala, right? The cannabinoid pathway has been downregulated. And so that pathway, which would help us naturally soothe ourselves, now has a reduced ability. The GABA pathway is downregulated. So even if our body starts to produce its own GABA, its ability to do so and to absorb it is impaired, right? And we go up on dopamine. We go up on glutamate. We go down on magnesium. So lots of things are happening all at the same time. And let's take a look and see what that looks like in a graphic. All right. So we're looking at alcohol withdrawal syndrome. And special thanks to Jose Maldonado of Stanford University, who published some very exciting new work on treatment of alcohol use disorder, and he gave me permission to use this graphic. So when we go down on the GABA, let's start there. What happens? So what happens is that the dopamine goes up, right? There's that interneuron process there. Dopamine goes up. And so we get hallucinosis. That's one of the things that happens, right? The GABA also affects NMDA, which now goes up. And now we can get DTs. We can get alcoholic withdrawal seizures. The magnesium is down. So we have norepinephrine and sodium going up, and so on and so forth. So the things that we're at risk of are really quite serious. And the two things that are most serious of all is the alcohol withdrawal seizures, because of course we know how dangerous seizures are in ordinary situations to a person, and that adrenergic storm that is happening. It's a norepinephrine storm. And that's where we see, the tachycardia, the tachypnea, changes in temperature, changes in blood pressure, autonomic instability. Mood becomes bad, sleep becomes bad. All in all, it's not a pretty picture. All right, so can we safely drink? So if we're honest about what we actually drink, yes, we can. So the standard from the National Institutes of Alcohol and Addiction is that men no more than 14 to 15 standard drinks per week, women no more than 7 standard drinks per week, and binge drinking is the pattern of drinking that brings blood alcohol concentration to that magic number that anybody who's driving a car should not be at or over. Usually in the average man, that's 5 drinks in 2 hours, and women, that's 4 drinks in 2 hours. And what is heavy drinking? That's 4 or greater days of binge drinking a month. I'm sorry, greater than 4 days of binge drinking a month. So if we look at that and we say, wow, that's a lot less than most people drink. Well, it's not really. It turns out that a lot of the people we see who drink a lot are actually in the higher percentiles of this. And a lot of people don't actually drink this much or much, much more. So let's talk about that honesty thing. Are we actually honestly drinking these drinks that we think we're drinking, right? Are we really limiting ourselves, if we're men, to 14 or 15 standard drinks? If we're women, are we really taking 7 standard drinks per week? So here's one of the ways we lied to ourselves. We lied to ourselves by denying what is a standard drink, right? So a standard drink is 1 12-ounce, 5% alcohol beer, 8 to 9 ounces of malt liquor, 1 5-ounce glass of wine, 1.5 ounces of liquor, and so on and so forth. So it's important to get a very good and specific history. I've had people say to me, I drink 1 or 2 bottles a day. Turns out they mean 1 or 2 bottles of 40 ounces of malt liquor, which is quite cheap. So we need to ask carefully. Acetaldehyde, highly toxic. That's where we're getting a lot of these toxic responses from. Headaches, feeling lousy. It's also a carcinogen. And from there, the aldehyde dehydrogenase breaks that down to make acetate, and the whole thing ends up being carbon dioxide and water, right? So acetaminophen is competitive with that enzyme that is used in the metabolism, and that's where we can go into fulminant liver failure, all right? So we have to remind people that they need to count their Tylenol when they're drinking, and hopefully they're not using it at all, but all products that end in APAP, right? Brand names such as Norco, Vicodin, Percocet, Tylenol, codeine, and in over-the-counter meds like Excedrin, like cold medicines, etc. People need to be looking at all of those when they think about how much Tylenol they're consuming. And I think we're doing so far okay on time. Let's then mention briefly, by the way, that we get long-term damage to the body. Again, I think we all know this. We've all experienced people who are having brain problems, liver problems. We'll talk about cirrhosis and alcoholic hepatitis in the 2 presentations to follow, and the pancreas. However, we should just note that women metabolize alcohol more slowly than men, and women develop illness and die younger than men do. So, we need to keep that in mind when we're assessing where a woman is in her alcohol disease history. So, in addition, in general, there's an increased risk of cancer and kidney disease, increased risk of heart disease and stroke, and it's terrible for diabetes. So let's take a look at alcohol withdrawal syndromes. And they're not the same. We sort of lump withdrawal as withdrawal, but they're not, right? Some of them are quite low or medium risk. So lots of people will have withdrawal from alcohol, and it's going to be unpleasant, but it's not dangerous. So for instance, people will get tremors, they'll be irritable, they'll have trouble sleeping. This is fairly ordinary and can be treated usually symptomatically. Alcohol hallucinosis, actually, depending on what their history is, they drink too much, they start to hallucinate a little bit. This does not automatically mean that they are at risk for DTs, right? Let's take a look at the alcohol withdrawal syndromes that are at high risk. These include alcohol withdrawal seizures, delirium tremens. Of course, we have to treat this as it has a high mortality rate, 15% or more. So the problem is when people come into the hospital or they come into the clinic, we might not have that quality of history of knowing the patient, of access to the tests we might want, or knowing quite how much they drank. So we wind up treating everything pretty much all the same when we're taking people in for withdrawal. So again, let's take a look at what some of these things that we're concerned about are. We're looking at the concerns, the clinical syndromes, hallucinosis, DT, alcohol withdrawal seizures, adrenergic storm, depressed mood, sleep disturbances. These are the things we're going to tackle to bring the patient through withdrawal in pretty good shape, right? And to do that, we have to look at what are the mechanisms that we're working against. So let's just parse that a little bit more. Uncomplicated withdrawal is 80% of all cases. Begins within 12 hours of the last drink, peaks at 12 to 36 hours after the last drink. These are the common signs. I'm sure some of us as teenagers had the experience of drinking too much and experiencing some of these things. I did when I was 20. Happy 20th birthday. And usually subsides in 5 to 7 days with no treatment at all. Now, in unusual circumstances, it can last longer. But again, if somebody has some of these symptoms and they keep going for a while, that does not necessarily mean that this is a severe syndrome. Alcoholic hallucinosis can be up to 30% of cases. It relates to the length and amount of alcohol exposure. Begins on the first day as early as 8 hours out, peaks between 1 day and 96 hours out. So 96 hours is, let's see, that's 4 days after the last drink. These are predominantly visual or tactile hallucinations. And I remember gleefully the year I learned the word formication. Formication is from the Latin formis. I know what you were thinking, you naughty people out there. It is the tactile hallucination that ants or other bugs are crawling on your body. So auditory hallucinations are usually mild sounds to voices. They can be anxiety producing. However, the sensorium is clear, vital signs are stable as opposed to the DTs. Alcoholic hallucinosis has no predictive value regarding the possibility of developing DTs. So it's really important that your staff is watching this patient who's in for withdrawal. Sensorium staying clear, vital signs are stable, ordinary signs of withdrawal, we're okay. So, alcohol withdrawal seizures, 5 to 15% incidence, begins around 12 hours after the last drink, peaks 48 hours after the last drink. Usually, these are generalized motor seizures without an underlying seizure disorder, right? The greater the amount of alcohol consumed, the greater the risk for seizures, right? 1/3 of the subjects who develop alcohol withdrawal seizures will only experience one, 2/3 multiple seizures, often closely spaced. Only 3% of the cases will develop status epilepticus, right? So what's the difference between all of these things we've described so far and delirium tremens? So delirium tremens is 5% or less of cases. It's actually delirium, profound confusion, altered sensorium, hallucinations, delusions, agitation. 80% of cases of DTs resolve within 72 hours. And if not, the mortality is reported between 1 and 15%. With medical problems, mortality may rise. You need to monitor for agitation, insomnia, fever, autonomic hyperactivity. Patients will express terror, predominantly visual and sometimes tactile hallucinations. So who's at risk? Maldonado's team out at Stanford has done some interesting work around this, and they've developed a predictive tool, the Prediction of Alcohol Withdrawal Severity Scale. And these are things you might ask intuitively, but tries to help the clinician develop a algorithm based on, you know, do they have a BIL on admission? Have you been recently intoxicated or drunk? Have you gone to treatment? Have you ever had DTs? Have you ever combined alcohol with other medications that work at that GABA-A receptor, such as benzos and barbiturates? Have you been drinking and using other things, right? Is the patient's blood alcohol greater than 200? So on and so forth. So if there's a score of more than 3, then we look at prophylaxis or treatment, right? Prophylaxis, they're not showing symptoms yet, and we'd like to stop them from showing it, or treatment for the symptoms. Now, what are the things that we commonly use to measure whether a patient is showing symptoms of withdrawal or not? Of course, there's the CIWA, which is the standard at Northwestern, and we were also using it when I worked at Rush. It scores 10 symptom domains. However, 7 of the 10 are purely subjective patient reports. And that's problematic because nurses who are not used to working with alcoholics and not used to working with withdrawal syndromes often get anxious themselves. Patient says, oh, I have a headache. Oh, all right, that means there's withdrawal. Patient says, oh, I'm a little anxious, you know, and so oftentimes we wind up giving many more benzos than we intend to give. Another tool that they're using at Stanford, which I actually like quite a lot and want to do some more piloting around here at Northwestern, is the Alcohol Withdrawal Severity Scale. It's much less subjective, and it's known and unfortunately used much less. I think this is something that we all ought to be looking at because, again, many of the nurses in the general medical setting or in the ICU who are not working commonly with alcohol use disorder tend to over-medicate, be heavy-handed with benzos if that's the protocol we're using. So when we are scoring symptom severity, these are the scores we might look at. A CIWA score of less than 15 is mild, moderate 16 to 20, severe 20 plus. The alcohol withdrawal severity scale, slightly lower, but similarly you have a breakdown there. And very often we have protocols in place that have been developed. Certainly we had one at Rush that, you know, if the score is this, then you give this. If the score is this, then you give this. So that's one of the reasons why the CIWA is problematic, because again, if people aren't administering it correctly, they tend to overscore, right? So how do we assess the patient? I think most people here know how to do this. Blood alcohol level, UTOX, comprehensive drug screen, folks. I happen to think that this is very important, and I'm shocked at the number of emergency rooms that don't put in for UTOXs and comprehensive drug screens. Remember, urine drug screens don't surface things like methadone, don't surface things like Klonopin, and so on and so forth. Things that it's very important that we know that the patient is using as well. CBC with the differential, GGT is what some of us have learned to use, but it may not be all that useful. In fact, I don't order it much anymore because it usually doesn't tell me a whole lot. We also learned that the ratio of the ALT to the AST 1 to 2 is indicative of advanced alcoholic liver disease. However, really advanced cases tend to look normal. You know, the liver just isn't pumping out those transaminins the way they were. Obviously, we're looking for evidence of hepatic injury. We're looking for evidence of kidney disease. Keep your eye on tests coming down the line in the future. Ethyl gluconuride is a way of taking a look at alcohol use in the last 80 hours prior to the test. And the PEH tests that are coming up, that's phosphodiethanol tests, which actually show much further out, and some people are starting to talk about it as the equivalent of the hemoglobin A1C of alcohol to get a sense of how much people have been drinking. Remember, check vitamin B1, folate, thiamine. Thiamine gets stripped very quickly out of people who have been drinking and can cause cognitive problems. Obviously, an EKG if you suspect cocaine use, or if somebody is agitated and you're going to need to use antipsychotics, you'd like to get that ECG. Again, we want that careful drug and alcohol history. We don't want to be jumping to filling a patient full of benzos, because if they're full of methadone or other opioids, we can be causing a real problem, right? Remember, alcohol is often used with cocaine, which has no physiologic withdrawal, but certainly has an emotional one. You also want to know about recent use of acetaminophen, right? And what you want are signs and symptoms of that ABCDE. Not simply that the guy is a heavy drinker or a regular drinker. That may not mean that the patient has a use disorder. And of course, family history. You're always looking, if you can, for verifiable signs and symptoms of withdrawal, such as autonomic changes, visible signs such as diaphoresis. So what are the things we're going to tackle here? So if we're concerned about that rebound when suddenly the body is cut off from GABA and the glutamate rises suddenly, then one of the things that we've commonly looked at in the past is gabapentin. But we don't necessarily need to do that. You know, I'm sorry, what we've used in the past predominantly been benzodiazepines, but we don't need to do that. And there has been research looking at the use of valproic acid, which stabilizes the neurons very nicely. Gabapentin we're using more and more here at Northwestern. And again, stabilizes the system very nicely, raises the GABA a little bit, protects against seizures, very, very nice. And then, of course, we want to protect against that noradrenergic storm. So what are we using? We're using alpha-2 agonists for this, right? And what this does is it reduces those symptoms of hypertension, tachycardia, the nausea, and so on and so forth, right? And one of the things that's also nice when we reduce those things is that we also reduce things like hallucinations, tremors, and so on and so forth. So what have we used historically? Lorazepam is a very nice choice for the liver if we've got severe liver damage, because it isn't metabolized the same way as the other benzos are. But of course, it has a short half-life. Most people are familiar with the use of diazepam or chlordiazepoxide. These have very long half-lives. Clorazepate is used as well. I haven't encountered it commonly, but it is a part of some protocols. But the question is, we get the patient off of alcohol and onto this, and we send them on their merry way. Now they're full of long-acting benzos. What if the patient drinks on it? What if they use opioids? Then what? Have we really solved this person's problem or merely prolonged the agony? Turns out many other agents have been studied for the treatment of withdrawal. Benzos may perform better for seizure control in a few studies, but not on other measures. And actually, there have been quite a few studies with other agents. So valproic acid, Depakote, and carbamazepine, Tegretol, are very well studied. Carbamazepine is used in Europe for 30 years now, and in most cases seems to be as effective on benzos. Other drugs that have been studied, lamotrigine, topiramate, tiagabine, vigabatrin, Topiramate actually has a very nice profile for treatment of alcohol. Unfortunately, it has a rather rough side effect profile for cognitive and emotional, so we tend to shy away from it. Benzo-sparing reality regimens is a reality. Stanford claims they haven't had a person on a benzo in over 5 years. There are other GABAergic medication choices. We have been using a lot of gabapentin, and we find that it works very nicely. We hit them with a heavy loading dose and then keep them at high levels and step them down. We pair that with an alpha-2 agonist. The one most commonly known is clonidine, but that could cause hypotension or rebound hypertension when it stops. It also isn't as selective for the part of the alpha-2 agonist, the alpha-2 receptor that we would like. So we've been using a lot more of guanfacine. Guanfacine, trade name Tenex. It's used as an ADHD drug in children. Very nice medication, but it actually has the highest affinity for the alpha-2 receptor, low risk of blood pressure changes, does cost more, but works very, very nicely. And when a person really is in trouble in the ICU, we may revert to Precedex dexmedetomidine, but this knocks the person out and stabilizes them very nicely. However, it's got to be in the unit, which is the most expensive way to do it, and it's thousands of dollars to use. So just a word about the B vitamins here. Again, we know that people will often give a banana bag. We want to talk about thiamine. There is a difference of opinion. Frequently, most people will use 100 milligrams PO daily of thiamine. The gut is pretty wrecked after all this alcohol use, so absorption is poor. The European standard is actually 500 milligrams IV TID for 3 days before converting to oral. We also do that at Northwestern Memorial Hospital, and when I was part of the consult team at Rush, that was also the standard we used. The British standard, 300 milligrams IV TID, and then throttle it back. Vitamin B12, the reason we worry about this is poor nutrition over a long period of time. Folate, again, we need to test and replete that because again, these are 3 of the vitamins most important in having good cognitive function. So I'm just about at the end of my time here, so I want to touch very briefly on after discharge. There's been a real nihilism in alcohol treatment, and we've had huge problems with prior authorizations of these meds until very recently in Illinois. So people would just discharge people and pray and say, go to AA. But there are things we can do. Naltrexone 50 milligrams PO daily has the best evidence of effectiveness. It's easiest to use, antagonizes opioid receptors. Number needed to treat is 12, lengthens time to first drink or to relapse, reducing our presentations back at the emergency room, relatively safe and well tolerated. There is an injectable version of this. However, there are small and poor studies on this. There certainly are anecdotal successes. I've had a few of them, and appropriate for somebody who really will compensate very badly and cannot adhere to PO. Acamprosate has the best evidence of effectiveness after naltrexone. We can use this in a person who has liver disease, severe liver disease, but not in kidney disease. Relatively safe and well tolerated, but it's TID dosing, and I don't frankly think that most people can maintain TID. We've already talked about topiramate, psychotherapy, very helpful, motivational interviewing, CBT, and treating of underlying psychiatric disorders. So this is the thing to remember. Nearly 15 million Americans have an alcohol use disorder. We have to address it, and we have to come up with better solutions because liquor companies have spent billions on getting people hooked. Nobody has spent billions on getting them unhooked. So we got to soldier forward, keep doing research, and do the best we can. I don't know if we have time for any questions because I know my colleague has a very robust presentation, so I'll stop there.
Thank you so much, Tony. That was wonderful, really informative. Now, I think we should wait for questions unless you have something pressing. You're welcome to type it in the message in the chat area, and we can look at those questions you have. Otherwise, we're going to switch over to Sarah's lecture. All right, Sarah.
All right. All right. Hi, guys. Thanks for sticking with us. So my name is Sarah. I am a nurse practitioner at Rush Medical Center in the hepatology clinic and with hepatology and liver transplant. I have the same slides as Tony does, so I'm going to kind of skip through those. All right. So I think Tony did a really good job of like kind of showing us, you know, what constitutes one drink, how much is safe in, you know, for the normal person in the general population. But so for women, you know, we don't have as much that we're supposed to or quote unquote allowed to drink. About 1 drink a day for women, up to 2 drinks a day for men. So that equates to, you know, roughly 7 drinks or less per week for women and less than 14 per drinks for men. And sometimes I get questions, they're like, well, you know, from patients and friends alike, they're like, well, if I don't drink during the week, can I do like, you know, 7 on Saturday? Is that still safe? And the answer, of course, is no, because then that constitutes, you know, binge drinking. So you have to remember this is a daily intake, not, you can't, you know, bogart them for the end of the week or on the weekend. And then you always want to remember, you know, what's 1 drink? And I think, again, Tony did a really good job that, you know, 12 ounces of beer equals 5 ounces of wine equals 1.5 ounces of hard liquor. And so, you know, a lot of patients who will come in will say, well, I don't drink alcohol, I just drink beer. And so it's just a lot of re-education to make sure that they understand that beer is in fact alcohol and can be just as detrimental on the liver as a shot. And same with wine too, or wine coolers is always a big one too. So when you do have these patterns of high alcohol content or binge drinking, that's when it brings that blood alcohol concentration to 0.08 or above. And for men, that's usually about 5 drinks in about 2 hours, and for women, it's about 4 more drinks in 2 hours. Sorry. Okay. So we're going to focus more on alcoholic hepatitis and alcoholic cirrhosis in the next 45 minutes or so. So alcoholic hepatitis is inflammation due to toxic effects of the alcohol on a chronically injured liver. And so usually you're going to see a lot of underlying liver disease when these patients present to you, typically in the hospital. And it usually requires about 10 or more years of chronic alcohol use. And I say typical because we've seen all spectrums across the board. I think my youngest patient that came in with acute alcohol on top of cirrhosis, she was 25. So I think that 10 years is, you know, just a guesstimate. It's not, you know, this is what it is. If you've only drank for 8 years, then you don't have any chance of having underlying disease, which is totally not true. And alcoholic hepatitis can occur with or without scarring or the cirrhosis. And some of the percentages I've seen in research has it anywhere from 85 to 95% of patients who present with acute ALCHEP already have underlying cirrhosis, which is a huge amount. So you kind of have to go in with your eyes open, thinking that when these patients present that, you know, you're already looking for, you know, underlying long-term damage. It does run a very high risk of mortality, but silver lining is that if they can achieve abstinence, you can actually recover from this, and you may still have underlying liver damage, but you can actually recover and go on to live a relatively, you know, normal life. All right. So the exact prevalence of alcoholic liver disease is really unknown. This is a couple of snippets of percentages that I got over the past like 14 years. So in '94, roughly about 7.5% of adults were estimated to meet the DSM-4 criteria for alcohol use or alcoholic dependence. And as Tony just showed us, now living in the US now, almost 15 million people have some sort of alcohol use disorder. So obviously, I think that number has gone up. In 2003, it dropped a little bit, but again, this is all meta-analysis data. And then in 2007, it was estimated that there were a little over 56,000 hospital admissions for alcoholic hepatitis just in the US alone, which accounts for 0.7% of all admissions across the US, which is a pretty high amount. So again, very prevalent, and I think Tony did a great job of demonstrating that as well. So when someone usually presents, I would say, usually you're going to see acute alcoholic hepatitis on the inpatient side as opposed to the outpatient side. And they're usually between 40 and 60 years of age. And again, this is all typical. This is what it is. Because again, I've had patients in their 20s and their 30s, in their 70s, in their 80s. So this is just a typical presentation. Most people that you see are going to be male, but women are definitely at the greater risk because we don't have the ability to metabolize the alcohol as quickly as men do. They'll usually present with some sort of fever, leukocytosis. A lot of times they'll have jaundice, so you'll see that elevated bilirubin. They usually come in with some ascites. They might be confused, and that can, be on a scale of a 1 to 4 with the encephalopathy. So they can come in just a little confused, or they can be completely obtunded. They might have hepatomegaly, so you might see that enlarged liver on imaging. And then usually they're going to have that long-standing alcohol use. And they could have stopped even several weeks ago, so they may say, oh, I've quit, but that alcoholic hepatitis can still present itself even if they've only stopped within a few weeks. So when you look at labs, someone comes into the hospital, the first thing you'd probably do is labs. There's no single marker that can definitively establish the etiology of liver disease, but there's going to be good indicators. So your AST is going to be about 2 times the upper limit of normal. And that's going to be about twice as high as the ALT. So you're going to see that 2-to-1 ratio. Rarely are you going to see it more than 300. If the AST is greater than 500, it's usually going to suggest something else, or there may be some overlap disease. So if it's just alcoholic hepatitis, the AST is going to be within that 200 to 300 range, or no more than 300, excuse me. You're going to see an elevated total bilirubin, which is why they're probably going to present you as jaundice. You may or may not see a high INR, just depends on how decompensated they are. And then on imaging, you're going to see that enlarged liver, either on ultrasound, CT, or MRI. So the next thing you want to do is really get a good history from these patients, and it's difficult. Sometimes they're encephalopathic, so they really can't communicate. Sometimes they're evasive because they're embarrassed or ashamed of their drinking. So, trying to elicit some of that information can be really, really difficult. Or they lie to you because they just don't want to tell you how much they're drinking. There are some tools out there that, as the primary team can use before you kind of call in your bigger guns, like the social worker or the psychiatrist or NP psych consult. So you can use the CAGE questionnaire, you can use the audit questionnaire, which can kind of help elicit some more information. And then a lot of times too, if they come with their family, sometimes they're a good resource, but sometimes they're not. They have no idea, how much their family member or loved one is drinking. Either they don't see it, or they're not around, or the family member is hiding it because, again, they're, don't want to be upfront about it. So sometimes they're a great resource, and they say, oh yeah, this person, they drink way too much. I've told them for years it's too much. And sometimes they just have no clue. So the next question is that, you have your labs, you have a history, should I or should I not get a liver biopsy? And this is still you'll see some hot debates, I think, when you're rounding with your team on the inpatient side. It just depends on, the attending's preference. Typically, we only order a biopsy if your clinical diagnosis is in doubt, meaning that, the history doesn't really align, or the labs don't look right, or when you do your concomitant workup, there's a possibility of some underlying disease. So, if their Hep C level comes back positive, their Hep B level comes back positive, you're concerned about PBC or PSC, that's when you may want to get that biopsy to make sure there's no overlap. Because the pros of doing a biopsy is that if there is another underlying diagnosis, that you want to make sure you treat them correctly. Sometimes the treatment for alcoholic hepatitis can be toxic for other disease processes. The cons, if you're really, really convinced this is alcoholic hepatitis, the cons of a biopsy is that, it's not necessarily a procedure that's warranted. There's always complications whenever you do a procedure. So, these people are already coagulopathic, meaning that, they could bleed out, they could be infected, and they could die. It's not a benign procedure by any means. It's costly and it's not super convenient. Sometimes getting them to do interventional radiology or doing it bedside is not the most convenient thing or the safest thing. So I think it just depends on the patient's workup and, again, what your team is more comfortable with and whether or not a biopsy is appropriate. So if you do get a liver biopsy, the histology you're going to see on the slides, you're going to see this like macrovesicular steatosis, and with alcoholic hepatitis, you're going to see what they call Mallory bodies, which is a really like textbook diagnostic tool for alcoholic hepatitis. You're going to see some lobular inflammation and ballooned hepatocytes. And just remember, when you have the steatosis, you have the hepatitis, and you have the cirrhosis, all three of these things can coexist in the same biopsy. So when you get your biopsy results back, it may be a huge paragraph of everything that's going on, because they most likely will have alcoholic hepatitis on top of alcoholic cirrhosis. But the key indicators of ALK-HEP is the steatosis and the Mallory bodies with the alcoholic hepatitis. So when these patients, you're trying to figure out, what do I treat them with? What is their prognosis? Because again, it runs a high mortality rate. So these three models are good prognostic scoring when the patients first come in and you get that first set of labs. The first one we're going to talk about is the Maddrey discriminant function, or they call it the DF. The MELD score for a model for end-stage liver disease, which I'm sure you're all well versed with. And a lot of the MELD score is typically used with more, long-term liver disease or cirrhosis. And then the Lilly score we'll also talk about. So the Maddrey discriminant function, it's used to evaluate the severity and the prognosis of acute ALK-HEP. And it's really helpful in predicting the short-term prognosis, specifically within the first 28 to 30 days. And it's also helpful in determining what pharmacotherapeutic treatment, if any, is warranted for these patients. So that is the formula. If you are so interested in doing by hand, I would say 99% of people probably use the MedCalc app of some sort. So if you get a score that's greater than 32, and to get this score, you're using the PT test and the PT control, whatever your lab uses as the PT control, and your serum bili. And then if you're getting a score that's greater than 32, it has a pretty poor prognosis for 1-month mortality, ranging anywhere from 35 to 45%, which is pretty high. But it is also a good indicator to start steroids and or pentoxifylline, which we'll talk about in just a minute. So the MELD or MELD sodium, which is what people are using more routinely now, it's a scoring system that we use to assess the severity of chronic liver disease, typically more for people who have cirrhosis. Actually, it was initially developed to predict mortality of within 3 months of people who had undergone TIPS, but that subsequently was found to be useful in determining the prognosis and prioritization for liver transplant, and it's now used routinely by UNOS as well as Eurotransplant. So again, there is the formula for the regular MELD and the MELD sodium. It basically looks at the INR, the INR, bilirubin, and creatinine, and then the MELD sodium, of course, also takes the sodium into account as well. And when you're interpreting them, you're looking at a 3-month observed mortality. So obviously, the higher the MELD score is, the worse the observed mortality is. The MELD score, even if your patient has a MELD score of 50, the score cuts off at 40. You physically cannot have a higher score than 40 on paper. So 40 is obviously the worst, and you're going to have a pretty high mortality, whereas if it's a normal MELD score less than 9, your observed mortality is pretty low. And then the last one, the Lilly score, it will help risk stratify patients for people who have already gotten a week worth of steroids if you have alcoholic hepatitis to see if they're going to get better or if they're not going to get better. So it's a really good predictor if patients should be considered for other management strategies or should be talking about other forms of treatment after that first 7 days. So I, to be honest, had no idea what that Lilly model score, what it actually looked like until I looked it up, and it's pretty impressive. So again, I would use a MedCalc app. I would not try to do that by hand. So when you do the Lilly model after that first 7 days, it helps predict the mortality within the next 6 months. So the higher your Lilly score, the worse chance you have. Basically, if your Lilly score is greater than 0.45, your survival percentage is about 25. If it's less than 0.45, your prediction of survival in that 6 months is 85, so much better. So lower score indicates more improvement in response to the steroids. So after that 7 days, if their Lilly score is low, then you can continue the steroids because they're hopefully going to do well. If after the 7 days of steroids, their Lilly score is above 0.5, you should be discussing alternative management strategies with the patient and the patient's family. And you can kind of see that chart, that huge change of patients who had the high Lilly score versus the low Lilly score with prednisolone. So we're going to get a little bit into the treatments for alcoholic hepatitis after we kind of did the workup. We're going to talk about prednisolone, pentoxifylline, and N-acetylcysteine, or NAC. But I think the two best treatment options we still have to this day is abstinence and nutrition, which is obviously way easier said than done if you've been on that side of things in the hospital. Getting patients to maintain abstinence is very difficult. And getting them to eat is equally as difficult because they don't feel well. The last thing they want to do is eat, 4 to 5 meals a day. But those are the two things we're actually going to highlight. So prior to initiating any treatment, I think of any kind, but specifically with steroids, you want to rule out any type of infection. So when they come in, besides your, labs that you're going to do, you want to get cultures, blood and urine, a chest x-ray, and a diagnostic para if able. Sometimes they don't always have ascites, so it makes it a little bit difficult, but even if they have that small pocket, it's a good diagnostic tool that we have to rule out SBP. So prednisolone has been studied for over the last 40 years in both clinic trials and meta-analysis review. It's still the best treatment choice we have for treating patients with alcoholic hepatitis, and it has shown in all of those studies that it can improve short-term mortality, but long-term it hasn't been shown to be as helpful. But short-term it can improve the mortality. And the best evidence we have out there is that prednisolone is used in favor of prednisone, but not all pharmacies have prednisolone on formulary. I know at Rush we actually do use prednisone because that's what we have. We don't have the compound of prednisolone, but overall it actually was shown to be superior than prednisone. So this was a meta-analysis study from 5 clinic trials ranging from 1984 up to 2006, and this is when it was in a 2011 article, and it did show that prednisolone by itself does have that improvement in that 28 days survival by quite a bit actually compared to the placebo. So pentoxifylline, I think, has been another hotly debated medicine as of late. Originally, and I think it's actually still used in relation for pain, secondary to claudication and peripheral vascular disease. But I actually did not know that. I've never seen it used for pain from claudication, but I think it's still used. If someone has a discriminant function of greater than 32, you can consider it for therapy, especially if the prednisolone is contraindicated, meaning that they're infected, they're having renal failure, they're bleeding, and you really just can't give them that prednisolone because it'll make them worse. You can use pentoxifylline because that is what is the next best choice. It's been pretty widely studied with and without prednisolone, but it really has not shown to be very clinically significant, improving short-term or long-term survival in combination with prednisolone. So it's, the next best choice we have. Whether or not it works, it's one of those things you kind of just throw your hands up and say, well, it's all we have, so we'll try it out. So you can kind of see here this relationship between pentoxifylline and prednisolone versus prednisolone by itself, that 6-month survival. There wasn't a huge difference, showing that, it's not much better than prednisolone by itself. So the STOPA trials were really well talked about, I think, at AASLD a couple years ago. And this was in the New England Journal of Medicine in 2015 is when it first came out. It was the steroids or pentoxifylline for alcoholic hepatitis. It was a huge study that they did, multi-center, double-blind, randomized trials looking at the effect of prednisolone and or pentoxifylline. The primary endpoint was 28 days, mortality at 28 days. And basically the conclusion they found was that pentoxifylline did not improve outcomes with alcoholic hepatitis. And prednisolone had beneficial effects on short-term mortality, but not on medium or long-term mortality in terms of alcoholic hepatitis. And they did look at 4 different groups. They looked at, a complete placebo, prednisone and placebo, pentoxifylline and placebo, and then pentoxifylline and prednisone together. And you can kind of see here where at the beginning, prednisolone kind of went ahead of everyone else, and by that 6-month drop off and about as NAC or N-acetylcysteine, and we use it to treat acetaminophen overdose. I think probably most people have seen it a lot. They use it a lot in the ER when people come in with Tylenol overdose. It's also used to help loosen the mucus in patients with CF or COPD. So I think pulmonologists use this medicine as well, but I believe it's more an inhalation medicine from a pulmonary standpoint. I might be wrong, but I'm pretty sure it's an inhalation. But there was a study out there that it found to have an improved 1-month mortality if it was used with prednisolone in acute ALCAP, but did not show any improvement in a 6-month mortality compared to the prednisolone alone. So you can kind of see in this study here, originally it was showing in that first 30 days, it did show improvement, and then by 6 months it kind of tapered off. And the reason that those look like they're so far apart is that P was 0.07, so not a huge chunk of patients to look from, but still give us some indicator that you can use it along with the prednisolone to help improve that 28-day mortality. So nutrition, like what I talked about a few minutes ago, nutrition I think is going to be one of the most important tools we have in helping these patients recover from acute ALCAP. Most of them that come in, I think, are severely malnourished. They have that very cachectic look. They've lost a lot of protein, or they may not really eat well at home because they're drinking so heavily. And really, irrespectively of what you treat them with, their intake is a huge determinant in mortality. And so I think what's important to underline is that, you obviously want to get them to eat, but you really want to get your dietitian involved from the get-go when these patients get admitted to kind of help, get their diet situated right away, find out what their appropriate caloric intake is for how big they are. And if they can't take it orally, you may have to consider putting an NG tube down. But you really want to get that dietitian involved, I think, right away to help with this, because that's what they do. They help people nourish themselves. And then you can also, get the multivitamins and minerals going as well. A lot of these people will get the banana bag. They'll get their B1, their B6, B12, their folate, zinc, and selenium. So the last treatment arm we have, which I think is actually the most important, is abstinence. And that really you want to underline and make these patients aware that they are not going to get better if they cannot abstain from alcohol. It's so important that they stop drinking as soon as they come to you, because really all treatment of alcoholic liver disease begins with abstaining from drinking. So in follow-up care, when hopefully they are able to leave the hospital and they come see you in clinic, And you want to see how they're doing in the outpatient setting now that they're kind of back in their home and maybe around triggers from before they went into the hospital. So a couple things off the bat, you want to make sure that they're maintained on that steroid therapy for the first 28 days. A lot of times these patients will be in the house for 5 to 7 days, maybe longer. So you want to make sure they finish that 28-day therapy, and you want to make sure you start titrating it down after that 28 days. Not everyone titrates. I typically do because I don't like them to get that rebound effect. And then the patoxyphylline, is also, you can stop it at the 28-day marker. You can continue it if you wish. There hasn't, again, the studies didn't show that it was super helpful. But if the patients say, oh, I feel better on it, then it's not going to hurt them to continue it. You want to make sure that they're getting that good nutritional support that they were getting while they were admitted. So high protein, low salt diet, make sure they're sticking to that less than 2 grams of sodium daily so they don't have recurrent ascites or swelling. And the multivitamins that they hopefully got inpatient, the folic acid, the thiamine, you want to make sure they continue those. And then sometimes, these poor patients, they physically cannot get, 4 to 5 small meals a day. They just cannot do it. It's too hard. So you may want to consider, doing supplemental shakes like Ensure or Boost. But before you do that, you may want to just get the okay from your dietitian first, just to make sure there's no contraindications. Especially if they're diabetic, you want to make sure you're recommending, diabetic friendly shakes, because those suckers have a lot of sugar in them. And then the last thing you want to discuss is obviously their abstinence, and to make sure that they have not gone back to drinking as soon as they've gotten out of the hospital. This patient population has a really high risk of recidivism, especially I think within those first few weeks to months. When you first see them, they say, oh, I'm never drinking again. I don't ever want to feel that terrible ever again. And then as soon as they start to feel better, you kind of forget. You forget how sick you were. You forget how bad you felt. They kind of fall back into old habits. So I think, getting them into the specialty clinics right away, having them see a psych NP or psychologist, addiction medicine clinic, really whatever tools you have. And, I think a lot of times this is really well addressed when they're in-house. Hopefully, they're set up with appointments when they get discharged, or if it was discussed to do an inpatient, intense rehab program, you may not see them for the first 30 days because they're in an intensive inpatient rehab program. But if they're not, try to get into an outpatient rehab program. Okay, so kind of wrapped up alcoholic hepatitis, but like we talked about, a lot of people with alcoholic hepatitis have underlying cirrhosis. And just as a reminder, the cirrhosis is irreversible scarring on the liver due to chronic alcohol abuse. And again, we're using that greater than 10-year marker, but it doesn't necessarily have to be. And you're going to see that about 10 to 20% of chronic heavy drinkers develop severe forms of liver disease, such as alcoholic hepatitis or alcoholic hepatitis with cirrhosis. And in the last year, cirrhosis was actually the 12th leading cause of death in the US, and half of those deaths were actually related to alcohol. So just remember, it's such a huge population that I think goes, missed or untreated. So when you see alcoholic cirrhotics in clinical presentation, if you're going to see them in inpatient, they typically come in with acute alc-hep with underlying cirrhosis. We're going to focus more on patients that come to you in the outpatient setting without acute alcoholic hepatitis, with just alcoholic cirrhosis alone. Sometimes you'll see these patients that they're on your schedule because the primary, did some sort of imaging, and incidentally they found some sort of shrunken or nodular liver on exam, and they said, oh, I don't know, you have something wrong with your liver, go to the liver specialist. And sometimes these people feel totally fine. They have no idea their alcohol is a problem, no idea that they've caused this much damage to your liver. So I think a lot of times when you see them in outpatient, they may have some vague symptoms where they just don't feel 100%. They feel a little bit more tired than usual, but they just can't put their finger on what's wrong. And then some of these patients just feel totally fine. They don't feel sick at all. So if you're seeing someone who comes in with decompensated cirrhosis, meaning that the liver is already starting to fail, you're going to see, possibly one or all of these things. They may have some encephalopathy. They may have had recent weight gain with ascites or lower extremity edema. They may come into you and be like, I feel like I'm 8 months pregnant. I don't know what's going on. And it's all the ascites that's built up. They may have had a friend or someone tell them like, hey, you look kind of yellow, your eyes are yellow, what's going on? So they may have some icteric sclera, or they may have some jaundice. And then if they do have bleeding varices, usually you're not going to see that at an outpatient. I don't think I've ever had someone come in with, actively bleeding varices in an outpatient setting. Usually they're going to go straight to the ER. If you start throwing up blood or something that looks like coffee grounds, you don't usually come into clinic first. You go straight to the emergency room. If they come into you with compensated cirrhosis, they're really not going to have any overt symptoms of liver disease. They can have some more subtle signs like pulmonary erythema or spider angioma, but a lot of times they just feel not great, and they don't know why. They're just like, I've just felt fatigued, I felt weak. The primary's done a great work of it, checked their thyroid, it's checked for anemia, all these things, and they just can't figure out what's going on. And sometimes the reason they can't figure out what's going on is because the laboratory studies aren't showing anything. The liver enzymes can be totally normal in these patients. So when they come into you, and you're suspicious of alcoholic cirrhosis, but you're not totally sure, you always want to make sure you rule out concomitant liver diseases first, especially if it's never been done. So you want to make sure you're looking for autoimmune diseases, viral diseases, or hereditary diseases. Specifically, autoimmune hepatitis, the antiphospholipid, hemochromatosis, alpha-1 antitrypsin, like all those, more abnormal hereditary diseases, just because you want to make sure that you don't miss anything. And I think another important factor too is that they could have alcoholic cirrhosis and some other other overlapping disease. It doesn't have to be just one or the other. I think a lot of patients, when they come into me, they say, oh, well, I only have this one disease. I couldn't possibly have another one. My liver only gets one disease at a time, and that's really not how it works. So you have to make sure you educate them to make sure that, you have this disease and this disease, so we need to treat both. And I think sometimes too, if they hear, something that's curable, like hepatitis C, they kind of forget about the alcohol. They're like, well, if I treat my hepatitis C, I can still drink because my liver disease is related to, hep C, not alcohol. And definitely have to re-educate that, just because you have this one disease, you still want to make sure you maintain abstinence, because alcohol still poses a threat. So the laboratory studies, after you do your hopefully good concomitant workup, the things you're probably going to order, a CMP, CBC, PTINR. So just remember that these patients can have totally normal liver enzymes. They don't necessarily have to be elevated if they have pretty well compensated cirrhosis, but if they are elevated, usually going to be no more than 2 to 3 times the upper limit of normal. And again, you're going to see that 2-to-1 ratio of AST to ALT. They may or may not have an elevated total bilirubin. Most likely, if they're cirrhotic, they will have low platelets and low albumin from that portal hypertension. And they may have a mildly elevated INR, but it could also be normal as well. So the labs may not really be, show anything to you when you get them, but obviously you want to work it up. So I think that the most important tools we have as clinician is doing a really good history, or as best we can, and then a good physical too the first time you see them. So the history, again, you can use that CAGE or audit questionnaire to kind of elicit, try to pull out, is their drinking a problem, how long they've been drinking. And I think Tony did a really good job underlying of like, well, if you drink, what kind of drink do you have? How much do you pour yourself? What type of alcohol do you use? How many times in a day or in a week do you drink? And then again, re-educating and understanding of what constitutes one drink. A couple of things that they'll ask them again, just to kind of elicit more information from them is, has your drinking ever possessed a problem at home? Have your friends or your significant other ever asked you to stop drinking, or they feel like, drinking kind of is consuming your life or causing problems? Have you ever, lost a significant other because of your drinking? Have you ever got fired from a job because of drinking? It's always an important thing to ask. And then obviously, or more obvious, is if they've ever had any DUIs. Can also kind of help you get more information too. When you're doing the physical exam, starting from head to toe, you're going to look at their eyes, make sure, see if they have that icteric sclera. You'll probably ask them some questions to make sure they're oriented and see if they have any underlying encephalopathy. You're going to look for ascites, so you'll do a really good, hopefully, abdominal exam checking for that tympanic versus dull sound. Going along with the, with the icteric sclera, making sure that they're not jaundice, which is usually pretty obvious when they come to you if they're lighting up bright yellow. A couple more subtle signs: the spider angioma or the palmar erythema. The spider angioma usually are going to see best on their chest area. That's where it's going to kind of be more obvious. Palmar erythema is one of those things where I think it can be really subtle and really hard to differentiate. Sometimes they come in, their hands are really red, and you're like, oh, this is pretty obvious. But sometimes you just see that subtle lining, and you have to, see if it blanches, see if it doesn't. But it's not always so obvious. So I think it's okay to kind of take a beat and really look at things closely and not, have to hurry through your physical exam to get to your next patient. But all these things are good indicators that they may have underlying cirrhosis. And then when you have your imaging, you're going to see either a shrunken and or a nodular liver on ultrasound, CT, or MRI. If they're coming to you for the first time, a lot of times when they're coming to you, if they have imaging, it's usually just a abdominal limited or that right upper quadrant, which is great to kind of look at the liver by itself, kind of rule out and make sure they don't have any cancer, but doesn't really give you a good view of everything else. You really want to assess for any splenomegaly, assess for portal hypertension, which you can do on imaging. So at minimum, I try to get at least a complete abdominal ultrasound just to get a look at the spleen. And then obviously a CT or MRI is a better modality to assess for hepatocellular carcinoma, and that can actually help you look for portal hypertension. Sometimes it can spot esophageal or gastric varices on that imaging as well, which is nice. So this I borrowed from our good friends in the radiology clinic. So on the left here, you can see what a normal CAT scan looks like. You can see that liver on the left side is really smooth. The spleen size is normal. And on the right side, if you see that white part on the left side of the screen, that's all bowel, so that's not part of the imaging. But you can see the liver is very, very nodular, uneven, and the spleen is much bigger than where it is on the right side on the normal CT scan. But hopefully you have a radiologist you can rely on, so you don't have to do these reads yourself. So long-term follow-up with alcoholic cirrhosis, I think it's really important, I think, as clinicians that, we're following these people closely and carefully and hopefully not letting them slip through the cracks. You always want to be on the lookout for recidivism. Ideally, if they're seeing you in clinic long-term, they've been able to achieve abstinence, but not always. People, they have slip-ups, they have setbacks. It happens. It's a disease. It's an addiction. So you can't expect that they're going to be 100% compliant all the time. Sometimes doing random alcohol levels or urine drug screens can be helpful. I don't typically do them unless I'm suspicious that, they're not being truthful, or if I'm concerned that they're, in trouble or they're getting sicker. Or sometimes I'll use it to confront them if they are flat out lying to me. I'll say, well, your alcohol level was positive. And they'll say, oh, I did have a drink yesterday. I forgot. The biggest thing with the alcohol levels is that you just want to be super careful if you're doing this in the outpatient clinic, because if you suspect that they're drunk or intoxicated on exam, and they've driven themselves there, you're legally liable now for that person. So if you're suspicious that they're intoxicated, you obviously want to try to, nudge them to go to the ER. If they're refusing to go to the ER, have someone else come and pick them up. You really don't want to let them get behind the wheel. So you just got to be really careful when you're doing, alcohol levels on outpatient. You want to see how they got there and make sure they're able to get themselves home if you're concerned that it's going to be positive. And then, even if they've been sober for, 6 months, a year, 2 years, I think encouraging relapse prevention long-term is super important. And having them see a specialist, or, some of my patients really like AA, some of them really hate it. It doesn't fit every person, but having them see a specialist who can really, make sure that they're maintaining that abstinence is really important in the long-term follow-up. Again, nutrition, super, super important. When they first come to you, they're, again, usually very malnourished. They're not making any albumin. Their protein levels are low. So having a registered dietitian kind of in from the get-go can be really helpful to get them, eating more regularly again. And then you always want to monitor for signs of worsening progression of liver disease. So you're always looking for the hepatic encephalopathy, varices, ascites, jaundice, and HCC. And we'll kind of touch on all these things quickly. So we're going to kind of start from head to toe. We're going to start with hepatic encephalopathy first. So it's due to high levels of ammonia that are unable to be cleared by the liver. And more than 40% of cirrhotics develop some form of hepatic encephalopathy, and that can range on anywhere from a grade of 1 to 4. So grade 1 is going to be sometimes really subtle. You know, they have like some euphoria or anxiety, they have a short attention span, maybe they can't, you know, add or subtract as well as they used to. You know, just a very weird lack of awareness. Sometimes it's even as mild as like disturbance in sleep patterns where they're having some insomnia, or they're sleeping more during the day. So things like that you kind of want to, when you talk to them, you try to want to pick up on and make sure they don't have any encephalopathy. And then it can range all the way to grade 4, which of course is when they're comatose or obtunded. You know, you can draw an ammonia level if you're concerned. Doing an ammonia level outpatient, not as easy as doing an inpatient because it does have to be run relatively quickly and typically has to be run when it's cold or on ice. So doing that in the outpatient setting can be a little bit more tricky, and you usually don't get very accurate results. And then sometimes, you know, the ammonia level can be normal and they're still encephalopathic, so it's not always a good indicator of whether or not they have encephalopathy. Luckily for us, there's great treatment out there for encephalopathy. Lactulose is always our #1 go-to. You know, it works really well, but patients hate it. You know, it tastes really sweet, sticky, and it makes you poop. You know, you're looking for those, you know, 3 to 5 bowel movements per day, depending on the patient. And so a lot of times they hate taking it. But the next tool we have is the Xifaxan, which works with the lactulose or by itself, depending on how well they tolerate the lactulose. And then neomycin is one of those meds that we used to use a lot. We don't really use it as much anymore. It does have a lot of side effects. And Xifaxan is honestly better if you can get it. The issue is pricing. You know, insurance doesn't always cover it. So sometimes you have to get your specialty pharmacist involved in helping with the Xifaxan. So next on the list is esophageal varices. And if you happen to have a biopsy with pressure gradients on these patients, if they have a gradient that's greater than 10, usually varices are going to be present. And if the gradient is greater than 12, it's really a good indicator that they have a high risk of bleeding. So again, if they can maintain abstinence, these varices in this grade, it can get better and actually resolve. So there are treatments out there. You can use a non-selective beta blockade. So propranolol, carvedilol, and nadolol are the best choices, or really the only choices we have to help treat the varices and keep those pressures low. I really like nadolol because it is just a once-a-day dosing. Propranolol is a little bit older, so it's a little bit easier to get. It just depends on your preference. And then, of course, we want to do screening endoscopies. They may or may not need banding. And if that doesn't work, you can always tips them to stop bleeding. So next is ascites, or that fluid buildup in the belly. And again, the best treatment we have is abstinence. So you can kind of see a pattern here. There was a study in a 2002 article that 75% had a 3-year survival who were child's class C, who were able to maintain abstinence, which is a pretty high percentage. So, and again, there's still that 25% of people that even with abstinence, they still may need help. So working with them on that sodium restriction, you know, less than 2 grams of sodium daily. And this can get tricky. You know, it's helpful if you have a dietitian at your disposal, but let's face it, you're not gonna have a dietitian at every visit. So a lot of this you're doing yourself. So really going through with them, you know, this is what has sodium, this is what doesn't. And I think a lot of things are deceptive. You know, you can see those low sodium soups in the aisle, but they still have a ton of sodium in them, and they're going to hit that 2,000 milligram daily ration pretty quickly if all they're doing is soups. Eating out, you know, there's always way more sodium and stuff than you think, especially if they're doing fast food, tons of sodium in that. So I think it's really working with them to make sure they understand, you know, what has sodium in it, what doesn't, and where the most notorious foods that out there that have sodium in them. You know, if the restriction doesn't work and they're still having ascites, you can always use diuretic therapy. When that doesn't work, you can tap them or do a paracentesis. And if that doesn't work, you can always TIPS them. So next is the hepatocellular carcinoma aspect. And actually in a couple of studies that I read, and this is going back to 2004 and then one in 2012, that the HCC incidence was actually lower in alcoholic cirrhotics than it was in other forms of cirrhosis. And it does not contribute as high to the mortality rate in alcoholic cirrhosis as other processes of the liver disease, but they still have scarring, they still have cirrhosis, so they're still at a higher risk than the general population for developing liver cancer, and you should still be screening them every 6 months. So this is a great slide that Vicki actually let me use. It kind of breaks it down between society or institution and then what their guidelines are. So AASLD, which I think a lot of us kind of look at, they recommend ultrasound with or without the AFP every 6 months. EASL is ultrasound every 6 months. The Asian Pacific Association study of liver disease was AFP and ultrasound every 6 months, as was the NCCN. And then the VA actually also said AFP and ultrasound every 6 to 12 months. I think the issue with AFP, and I'm sure some of my colleagues will agree, is that it's not always accurate. You can have someone with a raging HCC and their AFP is normal, it's 7, and it's like, well, this was not super helpful. So I think that's why the AASLD says, you can do it with or without, but the imaging is what is going to be your best conclusive evidence. So last but not least, liver transplant. So you have a patient who, has achieved abstinence and they're still sick. So we're looking at how do we know if they're sick enough to be referred to liver transplant. This is when we use that MELD or MELD sodium score. So typically they need a MELD sodium or MELD score of greater than or equal to 15 with indications. So they need to have they need to either have varices, ascites, encephalopathy that's being hard to control, or they have HCC. In our program, and I think most of the programs in Chicago, for an alcoholic cirrhotic patient to be referred to liver transplant, they also need a 6-month proven sobriety, meaning that documentation that there's been no relapses, and they also have to have engagement in relapse prevention. Here at Rush, we recommend, AA, but, like I said, AA doesn't fit everyone, and that's why sometimes they need one-on-one counseling, or they need, an inpatient versus an outpatient program, but they need to have some sort of engagement in that relapse prevention along with the 6-month proven sobriety. And, I think that 6 months sobriety is, kind of, it's not necessarily like textbook, like this is what's proven that they're going to stay sober after transplant. And there was a really good debate, the ALF liver debates talked about that at length, of that, is that 6 months, right for everyone? And sometimes it's not, but, it's sometimes it's insurance driven that they require 6 months, and sometimes it's institution driven. And then the last thing is the acute alcoholic hepatitis transplantation protocol. And this is relatively new within the past couple years, and you're going to see this pop up more and more. It has specific protocol in place. So these are patients with, very, very severe acute ALCHEP that are just not getting better despite all treatments we have available. They're just very, very sick in the hospital. They're melding between 30 and 40. And they're just not getting better. So sometimes you can ask, is this a possibility that they could fit this protocol? And it's a very specific protocol. At our institution here, and I think actually at all the centers that do them, this has to be their very first episode of decompensation, meaning that they can have no knowledge of their underlying liver disease. They have to have not known that their drinking was a problem, or had any, underlying knowledge that their liver was in trouble. They have to have really good family and social support, which can be tricky because sometimes people with, alcoholic liver disease typically, become more isolated and don't have good family support. So trying to get, the good support out of the Raptors can be tricky. They have to agree to engage in intense relapse prevention post-transplant, which is great in theory, but I think a lot of people will tell you whatever they have to if you're, trying to give them a life-saving alternative. So they'll sign every piece of paper you throw at them saying, yes, I'll do all this. My family will be here, but, I think talk is cheap. And so that's why it definitely becomes a riskier population to do. And the patients that we've done here at Rush have actually surprisingly done relatively well. And we're not talking about a huge percentage. I think in the Chicago centers, the most I think I saw was 3 a year. I think Rush did 1 or 2 in the past couple years. So it's a very, very small percentage of people that fit this protocol. But it is an option if you see these patients coming in sick. So if they do fit that criteria, you want to start making phone calls to see if a program near you will take them as a transfer to see if they fit that protocol. So a couple of key takeaway points. Alcoholic hepatitis carries a really high risk of mortality. Prednisolone is still proven to be the best option for treatment to reduce that 28-day mortality. As I'm sure you saw as a recurring theme, abstinence and nutrition are the cornerstones for improvement and recovery. Most patients with alcoholic hepatitis usually have an underlying liver disease or underlying cirrhosis. Close follow-up and management is key for long-term survival. And liver transplant can be an option for patients with alcoholic cirrhosis or acute alcoholic hepatitis if they meet the certain criteria. And that is all I got for you guys.
So thank you so much, Sarah. That was wonderful and very informative. And thank you to everyone else joining us. Please make sure to claim your CME that you complete the handout, the evaluation, and send it to the ALF. Also, Brandon, are you available just to give your email and any more information on that?
Yeah, a couple of quick things. So if you are listed on the phone as a caller and didn't register through the webinar, please send me an email, or you can type your name into the chat function just to be sure that I can send your name as a participant in the webinar so you can apply for your CMEs. Also in the chat, before we go into questions, I just shared the SurveyMonkey link that will actually take you to the survey that you need to complete for your CMEs. And that is directly through the Rush office. I will send that out in an email follow-up to all of the active participants today as well. So again, if you participated by phone and on the webinar system, I don't have your name, please add that to the chat. If you have trouble asking questions, you can chat the questions. Other than that, we can go into a Q&A. My email address, is bcombs. My last name is C-O-M. B as in boy, S as in Sam, as in combs his hair, at liverfoundation.org. Okay, thank you so much for both of our presenters and for all of our participants.
Thank you so much, everyone. And right now we're available to take any questions. If anybody has any, you're welcome to speak it or type it. Okay, if you guys have any questions later, you can always reach Brandon and he can reach out to the speakers. But this was wonderful, and thank you for joining us. Again, Brandon will send that follow-up email, and you guys all have a great evening. Oh, last thing, a reminder, we're going to have our next series in the suburbs in November, and that will be on fatty liver disease and obesity. Okay, have a good evening. Goodbye.